So what I think I'll do is I'll kick this off right now. We already have people joining, which we're delighted to have. And just as a brief introduction, I'm Marianne Faison. I'm the Executive Director of the Dallas-Fort Worth Business Group on Health, which is an employer coalition of about 50 or so different, mostly large employers that purchase health care for their employees in the Dallas-Fort Worth area. And this program, which is an interesting name, Peeling Back Hospitals 340B Pharmacy Scheme to Gouge Employers, is co-hosted by Chris Skizik with the Houston Business Group on Health, and he will give just a very brief opening as well. But let me just start out by welcoming everyone to this program. The big surprise for us is that we invited people from not just the Dallas-Fort Worth area and the Houston Business Group on Health area, Houston area, but we've invited employers from all the way across in all parts of Texas that we happen to have emails and were able to connect with you. So we actually have 260 people registered for today's webinar, and which just is a total shock to me personally. And this is wonderful. And we're glad that you all are joining to listen to this. We're going to talk about the 340B pharmacy scheme. It's a little known program that many employers and their employees certainly don't know anything about. But what it does, and I'll introduce our main speaker in just a second, is that it allows hospitals to purchase medications at a very steep discount, and then in theory use the very low cost of pharmaceuticals to help safety net institutions better serve low income and uninsured patients. But what it turns out is the price that they're charging employers and employees who are covered by the employers, extremely, just unbelievably expensive full cost medications. And employers are not getting any rebates for this either. So it's driving up the costs for employers, their pharmacy costs, just exponentially, especially for those who are using the high cost medications that are infusions in hospital centers and so on. So I'm not going to steal the thunder of Sean Greminger, who is our speaker. He is the CEO of the National Alliance, which is a composite of all the different coalitions around the country, and of which Dallas-Fort Worth Business Group, Houston Business Group are two of the many. There's about 50 coalitions around the country. And Sean is not only an expert on a lot of things, like leading a very large national coalition of employer-led coalitions, but he's also very knowledgeable about healthcare policy. So now let me turn it over to a brief comment by Chris Skizik, the Executive Director of the Houston Business Group on Health, to talk about what this program is going to do and what our opportunities are to offset some of the legislative policy that's in place or going to be in place.
Great. Well, thank you, Marianne, and you, like me, maybe not surprised at the number of registrants we have for this. There's something to be said about a good title, Gouging Employers. And quite frankly, that's exactly what's happening as these drugs are purchased by hospitals and developing contract pharmacies and selling them to employers at a very high price relative to their purchase, and they weren't even supposed to be intended to be sold to employers. And then, as Marianne mentioned, the loss of rebates. There is one thing, and we'll ask it now, we'll ask it at the end. There is a bill that is being heard tomorrow in the legislature. It's House Bill 3265. And we are opposing this bill in Texas because it solidifies the contract pharmacy relationships that have, quite frankly, bastardized the intent of this. And so in the chat, you will see a link to a letter that you can sign on. And what you do is you just enter your information in there as an employer saying you oppose this. We want employers to oppose this and send this message to the legislature. I can promise you the hospitals in the state are fighting very hard to make sure that this bill continues as it is. Legislatures react when they hear employer voices. So again, in the chat, we'll mention it again. You can click on that, copy it, and it has to be done today because the hearing is tomorrow. So we appreciate your attention. And I think after you hear Sean, you're gonna, I like the word that one of my peers said, enraged to engage. So we hope you will find this a compelling reason to sign on and support opposition to this. So thank you very much for attending.
Okay, and thank you for attending, like Chris said. So now I'm going to turn it over to Sean Greminger. You will have an opportunity to ask questions. He will speak for maybe about 30 minutes or so, and then do the working with you all with your questions. And I know he has wonderful answers you're really going to want to hear. So Sean, take it away for us. And thank you for bringing it to us, Sean.
Thanks very much, Marianne. Thanks, Chris. And thanks to all of you for being here. It's a real pleasure to be virtually back in the state of Texas. It's not my home state, but a state where my folks and most of my extended family are from. And it's always a pleasure. Everything is bigger in Texas. We've got a terrific terrific attendance for today's event. And hopefully you all will find this both entertaining and interesting. So let's talk about our agenda. First, I'm going to spend a few minutes talking about 340B as a program, where it came from, where we are today, kind of what happened to get us there. I want to spend plenty of time on 340B's impact on employers and working families, because I think that's the aspect of the program that is least well known in a lot of conversations. Talk about the kind of current reform proposals and some of the factors influencing the landscape, and then discuss how you can be involved. As Marianne said, feel free to put questions in the Q&A. I will kind of answer those as we go along if I'm able, but we'll have plenty of time at the end for sort of deep dive Q&A. And with that, let's go to the next slide. So just actually very quick background, whether I like it or not, I have been involved in the 340B program literally my entire professional career. As Marianne said, I am now the CEO of the National Alliance, but have been working in health policy in DC for 20 years and really started working on 340B all the way back in 2005, which is a really important year that we will note in a few minutes. So I've sort of seen all aspects of this program and have seen it sort of change in ways that were sort of unexpected. Okay, so go all the way back to 1992. Actually, let's go all the way back to 1990. So in 1990, Congress felt like, gosh, we're spending way too much money on healthcare. Funny, considering how much more money we're spending today. And Congress came up with, in a bill called the Omnibus Budget Reconciliation Act, OBRA of 1990, said, hey, you know what we're going to do is we're going to say we want to save some money from the Medicaid program, which of course purchases healthcare for low-income individuals around the country. And they said one way to do that is to stop paying as much for drugs. So they instituted what was then called and continues to be the Medicaid Best Price Rule, which effectively says that Medicaid is able to purchase drugs at whatever the best price is in the market. So they go to all of the drug makers, and they say, whatever your best price is, that's now the Medicaid price. You can't charge us more than that. Well, previous to 1990, some drug makers had been offering voluntary discounts to certain safety net providers, so particularly community health centers and sort of large urban safety net hospitals. And when the Medicaid Best Price Rule came in, the drug maker said, look, I can offer this to you, but I can't offer it to the entire Medicaid program, which is a large program. So we're no longer going to offer those discounts. Not surprisingly, the community health centers and the big public hospitals said, that's a problem. My drug costs just went up. So they went to Congress and they lobbied to say, hey, can you do something to fix this unintended consequence of this legislation? That's where 340B becomes involved. Interestingly, there are roots of this program in Texas. The public hospital CEO that testified in front of the Energy and Commerce Committee when the law was first written was the CEO of Parkland there in Dallas. And Parkland is maybe a good example of the kind of hospital for which 340B was originally created. So what 340B says is kind of as Marianne described. It says certain covered entities, that's the federal parlance for 340B providers, can purchase drugs at a steep discount over how they would otherwise be able to purchase it. That's called the ceiling price. And with those savings, so instead of purchasing a drug at, say, $100, they're able to purchase it at $50. With those savings, they can and should reinvest that money into the communities and the patients that they serve. So that could be, we're going to offer discounted drugs or free drugs to our low-income patients. We're going to use some of that saving to build, a clinic or some sort of program in a low-income neighborhood in a rural or urban area. That was the original idea. The program has changed fundamentally, which we'll talk about in just a minute. But you can see on the right hand side of this document is actually the committee report from 1992 that says here's the sort of set of types of covered entities that qualify. You can see section 6, certain public hospitals that blah 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 blah. And they estimated at the time that category would encompass basically 90 hospitals, more or less. Parkland, Harris Health in Houston, University Health System in San Antonio, right? Core urban safety net hospitals were kind of the original focus for this program. I like to say that 340B was considered to be so small and inconsequential, they didn't even bother giving it a name. The reason it's called 340B is it's literally built into Section 340B of the Public Health Service Act. And it was never thought of as being anything more than just a way to help offset the unintended consequences of a bill or a law that Congress had passed 2 years earlier. Next slide. So very briefly, there are a bunch of different types of organizations that can participate in 340B. You can see them listed here. Federal grantees, which is really a set of organizations that all receive funding from the federal government to help care for uninsured and low-income people through what is called HRSA, the Health Resources and Services Administration. Probably the one that people most know about are federally qualified health centers or community health centers. That's the biggest, sort of the bulk of federal grantees, but there's a whole bunch of different ones. Family planning clinics, Ryan White AIDS assistance clinics, tuberculosis clinics, urban Indian organizations, you name it. And then a set of hospitals. Now, to qualify on the hospital side, it depends on each type of hospital, but you have to have a certain percentage of your patients need to be low income. So I want you to look at that slice, kind of the second blue one from the left, disproportionate share hospitals. We're going to be talking a lot about DSH hospitals here in a minute. When the program was originally created in 1992, it said to qualify as a DSH hospital is basically any freestanding acute care hospital. You have to have a DSH adjustment, a disproportionate share hospital adjustment of 11.75. You don't need to worry about how the DSH adjustment is calculated other than to know it is a function of really two things. The percentage of your patients who are low income, by which they used kind of the proxy they used was Medicaid patients and low-income Medicare patients. So that's Medicare patients that also qualify for supplemental security income. So think sort of poorer Medicaid patients and Medicaid patients, divided by your total number of patients. That's how you arrive at your DSH adjustment. And 11.75 means that, roughly 12% of your patients have to be either covered by Medicaid or be low-income Medicare patients. In 1992, 90 hospitals, or maybe 100, qualified for the program. Today, Medicaid is much larger than it used to be, to the point that now almost a quarter of the people in the United States qualify for Medicaid, but the DSH adjustment hasn't changed, which means a lot more hospitals have qualified. Let's go to our next slide. So if you look, this is data from 2023. We don't have 2024 data yet. You can see sort of where 340B dollars have gone. The vast majority, more than 3/4, are going to those DSH hospitals. Relatively small portions going to the HRSA grantees that we talked about. Some of the other hospitals like rural referral centers, freestanding children's hospitals, cancer hospitals, critical access hospitals, which are kind of your typical small rural hospitals, 1%, et cetera. DSH hospitals now make up the vast majority of 340B revenues. And by way of example, the types of hospitals that are heavily leveraged in 340B, a program designed to help safety nets, are places like Dallas Methodist, Houston Methodist, Memorial Hermann, Baylor Scott and White, places that you probably don't think of as being core safety net hospitals. Next slide. All right. This is the slide that I want you all to remember, among others. When I first started working in 340B, it was 2005. And I will fully admit I was working at the time for the Children's Hospital Association, and one of the first bills I ever lobbied on was bringing freestanding children's hospitals into 340B. Was that a good decision? Let you decide. We all love children's hospitals. They do great work. They're also super expensive. But either way, they qualified for 340B in 2007. 2011 was a big year for 340B. So in that year, several things happened. First, some new eligible hospital types were added. So critical access hospitals, et cetera, were added to the program. But as you saw, that didn't really make a huge difference, or they're not a huge portion of 340B revenue. Second, the ACA Medicaid expansion occurred. So I know Texas has actually not taken up the Medicaid expansion as an option, but in many states, they started to expand their Medicaid program, which means more people moved from being uninsured, where they interestingly were not, their numbers were not used to quantify or to qualify hospitals for 340B, into the Medicaid program, which means that many hospitals, DSH adjustments went up. So more and more hospitals started to qualify. The other thing that happened is the contract pharmacy expansion. So I'm going to take a quick step back and talk about contract pharmacy, and we'll go through this in a little bit more detail. So this also has, like so many other things in 340B, sort of a reasonable kind of decision by HRSA that has been badly misused. So all the way back in like 2008, 2009, some of the small community health centers said, hey, I can't really participate in 340B because I don't even have my own pharmacy, right? And to qualify for 340B, you have to qualify as a covered entity and you have to have a pharmacy, but for which you can purchase low, drugs at a cheaper price. And so HRSA said, okay, well, why don't we try something out? We'll just do a pilot and we'll say every covered entity, every hospital, every community health center, every Ryan White AIDS clinic can have a contract with one local pharmacy. So find the pharmacy nearest you or the one that tends to fill most scripts for your patients, and you can contract with them. You can arrange your own contract details, but usually you pay them a certain fee for administering your 340B program. Maybe you give them a larger than average fill fee. And then, when they sell the drug, they're able to buy it at a discount. They pass the discount on to you. All good. Well, that worked so well that the covered entities went back in 2010 and said, hey, that's working great. Why just one? Like, we've got patients all over the place, particularly some of these large hospital systems. Can we have more contract pharmacies? And HRSA made the decision at that time to say, sure, we'll have an unlimited number of contract pharmacies around the country, which means that most covered entities today, particularly the big DSH hospitals, can have as many contract pharmacies as they want. Many of them have dozens, if not hundreds, of contract pharmacies. So if you're a patient at a 340B covered entity and you go to any one of their contract pharmacies, which is a lot of contract pharmacies, Walgreens, et cetera, the hospital is now able to take advantage of that 340B eligibility. So you can kind of see the numbers here, depending on where you want to sort of start the clock, but let's just start with 2011. The program has grown from, $6.4 billion to, in 2023, $66.3 billion in total discounted drugs. It is now the second largest government pharmaceutical program in the country after only Medicare Part D, which means more drugs are filled through 340B than Medicare Part B. More drugs are filled through 340B than the Medicaid program, which is the original sort of source for why the program was created. And the reason for that, as I'm discussing, we'll discuss more, is that it is incredibly lucrative and it has almost no oversight by federal officials. Next slide. I wanted to just quickly address one. This is a similar looking slide. You'll kind of see the green graphs look very similar to the ones you last saw. They are the same, except it ends in 2022. One of the arguments that we hear from the covered entities is to say, well, look, the purpose of 340B is to let us stretch our resources, cover more people, do better work, help the low-income populations that we're serving. And yet, by at least one measure, maybe the most obvious measure, which is charity care, so free care that hospitals and other covered entities provide to uninsured people, those numbers have actually fallen since 2012. Probably the reason that we actually see lower charity care is Medicaid. The Medicaid expansion has meant that more people have gone from being uninsured into the Medicaid program, which does provide reimbursement. But you can see a pretty significant delta in the growth of 340B, which is designed theoretically to help covered entities, hospitals, provide more care to low-income people, and the amount of care that they're actually providing to low-income people in terms of charity care. I think it's a really important point because as you engage in this, you will hear from hospitals to say, well, here's why we are in this program. We're doing all of this great stuff, and we have at least have some good examples to show that that's not happening. Next slide. So I'm not going to go through this entire thing in great detail, but this is a rough sketch of how the 340B program works. As you can see, it is very much the economists would say a price arbitrage program, but it's buy low, sell high. So if you're a 340B hospital and you're able to buy a drug at a discount, sometimes it's more than this, but a 50% discount, the drug that you would normally pay $1,000 for, you can now buy at $500. Okay. Increasingly, 340B hospitals have then been going out of their way to make sure they're serving as many commercially insured patients as possible. Because again, think about the types of places that are now qualifying. It's Houston Methodist, it's Memorial Hermann, it's Baylor Scott and White. Whenever they fill a script for a commercially insured patient, the patient receives no benefit. The employer receives no benefit. The hospital is able to take that difference, the lower price they paid, and the markup, or the lower price that they purchased at, and the markup that they're able to demand from us, and it all goes into net profit for the hospital. And I want to just say one more time, there is no requirement in federal law that hospitals share any of those savings with patients, with payers, with anyone. In fact, there's no requirement whatsoever. They're able to do whatever they want with that money. So you can see we are paying quite a bit for drugs that they are buying at a steep discount. And we're going to talk a little bit more about how that works in a minute. Next slide. This is a slightly more complicated graph that basically looks at how this works in the contract pharmacy arrangement. So some 340B drugs are filled through the hospital-owned or community health service-owned pharmacy. When a contract pharmacy is involved, you now have another party that needs to get paid. So I'm not going to make you sort of follow through all of the gray and gold lines. But suffice it to say, the contract pharmacy, if let's say the patient receives a drug, has a script from a doctor or a clinician who's affiliated with a 340B pharmacy, 340B covered entity. They go down to their local Walgreens, which happens to be a 340B contract pharmacy, or they get it filled through a mail order pharmacy that happens to be a 340B contract pharmacy. The contract pharmacy is able to, they bought the drug at the 340B discount. They sell the drug at the commercial price point. They pass on the savings or the additional revenue to the hospital. And the contract pharmacy makes a lot of money too, because they're receiving sort of very large reimbursement for every drug that they fill under 340B. By way of example, we've seen examples where a contract pharmacy might get a $3 script fee for one drug or for a drug, but if that drug is filled as a 340B drug, same distribution, same system, instead of getting $3 for it, they get $20 for it. So you can imagine the CVS's, Walgreens, Optum Rx is doing this through mail order side, love participating in 340B because they're able to make a lot more money on being able to take a slice of that price arbitrage than they would be if it was not covered under 340B. Part of the reason why the insurers have not been helpful to us on this rapid growth of the program, because they themselves, through their PBMs and their contract pharmacies, are making a lot of money on the program. Next slide. All right, so why does it matter to us? Maybe it's obvious to you, but we actually have some really good data that shows not only are we're paying for that difference, but we're actually paying even more than we otherwise would. So let's go to our next slide. I want to make sure, is this the slide after the last one? Yeah, okay. So for one, it is very clear that 340B is driving horizontal and vertical consolidation. So this is something that I know Dallas-Fort Worth Business Group on Health, the Houston Business Coalition on Health have probably talked to you a lot about. Over time, the hospital industry in the last 20 years, and particularly think about sort of where that takeoff was in terms of the size of 340B, the hospital industry has become highly consolidated, right? Hospitals buying hospitals, so we have larger sort of mega systems within geographic areas, horizontal consolidation, and hospitals buying physician practices. I didn't make this note, but maybe it's clear. 340B once a hospital has qualified for 340B, so the core hospital in the downtown area or whatever, once they've qualified, all of the outpatient clinics affiliated with that hospital are now 340B covered entities. They call them child sites. So if you are a large hospital system in San Antonio and you've got hundreds of outpatient sites, all of them get to qualify, even if that outpatient site happens to be in a very wealthy suburb, treating almost no uninsured or Medicaid patients. Every script that you write in that child site is now a 340B drug. You can imagine when you're a 340B covered entity, you're making a lot more on the sale of drugs than somebody who doesn't qualify for 340B. So a kind of obvious example is in the oncology space, where you have very expensive drugs. If you're a independent oncologist, you don't get to participate in 340B. You write the script for the drug, the person goes and gets it filled. That's that. Or even if you are writing the script for the drug and it is physician administered and you're administering it in your clinic, you're able to make a little bit of a margin on it, but not the kind of margin that you would be if you just went ahead and sold out to the large hospital system who's been trying to buy you anyway. So now these hospital systems have a profound incentive to engage in more vertical consolidation, because the more outpatient sites they have, the more money they can make in this program. I think everybody already understands this, but to be very clear, the academic evidence is overwhelming. I mean, it's mountainous. The larger a hospital system is, the higher their prices are. The more consolidated a market is, the higher the prices are in that entire market. So we want to do everything we can to try to discourage further consolidation in the healthcare industry. Part of the reason why we've been really critical and concerned about 340B. Next slide. I've discussed sort of the explosion in contract pharmacies. CVS Health, Walgreens, Walmart, Express Scripts, Optum Rx, all of these are what they are. You know, they're for-profit entities. They're doing their job to return value to shareholders. They are making billions of dollars in a program that was originally designed to help low-income people have access to drugs. I want to look at this JAMA article, so this article from the Journal of the American Medical Association. One of the things we have seen is 340B hospitals are not taking their 340B dollars and opening up new pharmacies or contracting with pharmacies in low-income areas. In fact, between 2011 and 2019, the share of 340B retail pharmacies in disadvantaged areas actually declined. Let that sink in for a minute. So a program designed to help low-income people in underserved communities, we've actually seen the number or the share of all the contract pharmacies they have in low-income areas has gone down, which means that the share in high-income areas has gone up. Why? Well, follow the money and think about the profit motivation. If you are a large hospital system that participates in 340B, wouldn't you rather have your contract pharmacies in Bel Air and Katy than on the east side of Houston, or whatever the equivalent is in Dallas? I just happen to know Houston a little bit better. Plano versus, I don't know, the east side of Dallas. Next slide. Very strong evidence that shows that 340B covered entities do two things that are obviously problematic from the employer perspective. So one, they actually mark up the price of their drugs more than non-340B covered entities. Two, they prescribe more drugs than 340B covered entities. So you can look at sort of two practices that are otherwise similar. On average, the 340B covered entity practice is going to actually prescribe more drugs than the non-340B practice. They're going to mark up the price of those drugs higher, and they're going to prescribe higher priced drugs. Again, now 340B hospitals are sort of in the same game that the PBMs are in, and I know you all are kind of well educated on PBM games. A PBM would rather administer and negotiate a higher price drug because they get to take a bigger slice of the rebates. Same thing for a 340B hospital. If you've got a drug if you have two choices, you know, a $5,000 drug and a $2,000 drug, guess what? The hospital's going to make a lot more if it's a $5,000 drug because they're able to take the price arbitrage than if it's a $2,000 drug. So not surprisingly, we're talking about more drugs, higher priced drugs, and a higher markup. You can see one example from the North Carolina state treasurer. They just looked at, hey, how much is this program costing just the state health plan? So they were just looking at taxpayer dollars. what is this costing for the state health plan, which is obviously the employees in the state of Texas, or excuse me, state of North Carolina. What they found was that the average markup for 340B was 5.4 times the acquisition cost of oncology drugs. Next slide. Next slide. All right. So let's talk about sort of nuts and bolts, what it actually means to employers just in the state of Texas. So we're really pleased that we were able to work with the National Pharmaceutical Council and a research company called IQVIA to look at just one particular aspect of this. And again, this may or may not have been obvious in my previous slides, but if you think about when a drug gets prescribed, it's under, let's say you've got a 340B drug and a non-340B drug. So it really just depends on who was your prescriber, right? Was it a doctor affiliated with a 340B covered entity or one that wasn't? If it's the one that wasn't, right, just a regular doc, not affiliated with a 340B covered entity, they prescribe the drug. You go down to your local pharmacy. You pick up the drug. They look at your health plan. They say, all right, you owe your $20 copay or whatever it is. And then they send that script or they send that receipt over to your PBM, who then determines how much is the price of the drug, the remainder of the price of the drug to the employer, what's the rebate, et cetera, and then ultimately the bill gets sent to the self-funded employer. So it runs through your PBM plan. Under 340B, it doesn't. So the way it works, and it's complicated and pretty opaque, but the way that it tends to work is from the employee perspective, it's the same thing. You go down, you pick up the drug, you pay your $20, it gets sent in through the system, but before it can get to the PBM, there's an identifier by the pharmacy to say, hey, this is a 340B patient. So instead of the drug flowing through your PBM, where you're going to receive your rebates or the share of the rebates that the PBM is ultimately going to pass on to you, it flows in through a 340B channel, which means you lose all of your rebates. So I want to just say it very clearly. As a self-funded employer, you're not receiving rebates on the drugs that are prescribed to your families. The loss in rebates to Texas employers is not insignificant. So on average, you lose $26 per beneficiary per year. The total cost of that for employers across the country, across the state of Texas is roughly $353 million. Of that, $57 million is actually cost to the state of Texas through their employee benefit plan in particular. We're going to talk about the contract pharmacy mandate in a minute, but there is a bill in Texas, and this is part of the reason why we are engaging here, that would require the use of contract pharmacies. It would actually increase your cost by an extra $6 per beneficiary, increasing the total cost of the program to commercial employers by $78 million, costing the state of Texas and local entities $13 million for a total cost of 340B just in lost rebates. So that doesn't count the other stuff that we talked about, just the lost rebates of $431 million a year. And then you can sort of see the way that we were able to kind of identify those numbers is looking at 340B utilization in Texas versus other states. You have one thing going for you in Texas. 340B utilization in Texas is actually lower on average than other states. Around the country, it's about 12% of all scripts are run through 340B. In Texas, it's only 7%. But like any other state, it is growing rapidly. Next slide. So, bottom line, the 340B program is directly and indirectly costing employers and purchasers and working families a significant amount of money. We talked about the horizontal and vertical consolidation, the lost rebates, the distorted prescribing patterns. And in the end, what's really frustrating is that the patients and communities that were originally designed for the program are not being better served. I want to pause here and stipulate for a moment. I'm talking about the program in general. There are a lot of safety net providers in the state of Texas, community health centers in both urban and rural areas, small rural hospitals spread throughout, the vastness that is Texas, core urban safety nets like Harris Health and Parkland and University Health System in San Antonio. Our perspective is those places should continue to get 340B. They need the money. It's very difficult to keep their doors open. We get that 340B can help do that. That's what the program was originally designed for. Our concern is not about them. It's about the vast majority of the rest of what's happening in the program, in which very large, often very profitable, tax-exempt institutions and contract pharmacies, PBMs, et cetera, are leeching money out of the healthcare system to the detriment of employers, purchasers, and working families. Next slide. All right. So why are we talking about this now? A couple of reasons. So let's go to the next slide. So there's a lot going on, both at the federal and the state level. I'm going to start at the state level because that's the most specific example. In Texas, there is a bill that, as Chris mentioned, is being considered in a state House committee tomorrow. It may or may not make its way over to the Senate committees, may or may not make it to the floor of either chamber, may or may not be put into law. Our goal is to try to keep it from being put into law. It would effectively mandate the use of contract pharmacies and kind of create a gag clause. So I'm going to take a quick step back to explain kind of how we got here. Starting about 4 or 5 years ago, pharmaceutical companies started looking at how much they were losing in 340B. And no surprise, pharma companies do not like this program for some of the same reasons we don't. Like we don't like it because it's increasing our prices. They don't like it because it's reducing their revenue. And they looked at contract pharmacies in particular, which is a huge area of growth, and said, you know, contract pharmacy isn't even really in statute. And it's not. It's actually kind of remarkable. Contract pharmacy was invented whole cloth by HRSA at the request of covered entities. The decision to make it nationwide or take the lid off and say you can have as many contract pharmacies as you want, also invented by HRSA without any sort of congressional oversight. And the drug maker said, I'm not sure I have to comply by contract pharmacies. So many drug manufacturers said, you know what, we're going to say, yeah, we'll continue to be in 340B. And if you're filling the script at the owned pharmacy at the hospital or at the community health center or elsewhere, no problem. But we're not going to honor contract pharmacy arrangements. Not surprisingly, the hospital sued. And at least at the federal level, the manufacturers have won so far. There's actually, it was an appeals court case in, I think, the Fifth Circuit, in which the appeals court said, yeah, I mean, it's not in law. It's not clear that they have to honor these relationships. So the American Hospital Association went down to the state level. So a program that has always been a federal program, never really had any state impact at all, or never had any sort of state attention at all, suddenly became a hot button issue in states around the country. This is where the National Alliances started getting involved. What states are trying to pass, including in the state of Texas, is to say, we're going to say that drug makers cannot restrict the ability of covered entities to use contract pharmacies. So effectively mandating that, contract pharmacies must remain in place. There can be no ability to limit them. The cost of that is significant. We've already talked about that. That's why the National Alliance, working with the Houston Business Coalition on Health, the Dallas-Fort Worth Business Group on Health, and coalitions in states all over the country, have been trying to oppose these same sets of legislation. Instead, we've been trying to actually push to say we need to have better transparency in the program. And there's a way that states can do that. So I'll just point quickly to, I mentioned to you the North Carolina example, where this is a report that was produced by the state treasurer. In Minnesota, the state actually said in their last legislative session, said, let's better understand this program. And so they required, as first state to do this, they required covered entities, hospitals and community health centers, to actually say, here's how much money we're making in 340B. Not just in the net or in the gross, but in the net. So after taking out money that we're giving to contract pharmacies and other third-party entities, what was the delta? How much money did each covered entity make? So we now have data from hospitals and community health centers and others in Minnesota to see who made how much money. I will note that it wasn't perfect because it only looked at drugs filled at pharmacies, not physician-administered drugs. They're fixing that problem. But the results were astounding. And the big takeaway to me was there is a single hospital in Minneapolis. It's called M Health Fairview. They are the hospital for the Academic Medical Center, University of Minnesota. Made more money by itself in 340B than all of the hospitals, or all of the states, rural hospitals, community health centers, and Ryan White AIDS clinics combined. So again, when the defenders of 340B say, hey, if you do anything about this program, you're going to harm rural hospitals, community health centers, Ryan White clinics, I think our response is, I don't know, man. In Minnesota, one very large, pretty profitable system made more than all of those guys combined. So maybe we could draft legislation that just protects the good guys, the ones who really need it, and doesn't allow, a single hospital in Minnesota to make, I believe the number was $120 million just in 340B price arbitrage just in 1 year. And that wasn't even including their physician administered drugs. So once we have that data in, we'll probably see that number get much larger. So at the National Alliance, we've been really pushing to say, don't mandate the use of contract pharmacies, which just expands the program and harms employers and working families. But if you want to get into this, do go ahead and get some more information on this program. Find out who's using it. Find out whether there's any benefit. Maybe ask some questions about how they're using 340B. Ask them to look into, like, are you actually building clinics in low-income areas, or are you doing something else with the money? We think that's a really valuable way for states to be involved in this program. In the end, real reform to 340B pretty much has to be done at the federal level. It's created in federal law. It's not regulated in state law other than some of these new bills. We're starting to see some movement on the federal side. I will say it's a ways off. Congress is focused on a lot of other things. And to some extent, Congress isn't doing anything about a lot of stuff. You may have seen this in the news. But it is certainly our goal to try to push Congress to say, you really need to take a closer look at this program. You're looking at significant cuts to Medicaid. You're looking at changes to the way the Medicare program works. You're looking at fundamental changes to the healthcare system. You should be looking, if you're going to do all that, you should be looking at the fastest growing and now second largest drug purchasing program in the country, which is effectively unregulated. That's the case that we're trying to make. All right, next slide. I think we're very close to the end and we'll have plenty of time for questions. All right, what's next? So how could you get involved? Well, first, I think being on this webinar is a first step. So learn more about the impact of 340B on your organization. Talk to folks in your pharmacy side and see if they can figure out to what extent you are impacted by 340B. I will say it's very, very difficult. Most employers that I talk to, you can't see the loss of rebates directly. There's no way for you right now to ask your PBM how much is flowing through 340B and how much isn't. But that's something that you should probably start asking your PBMs for. You should start asking them to say, we need to track what we're actually losing in terms of lost rebates in this program. Talk to to Chris and Marianne and their staff about what's going on in 340B land. So just stay involved. Second, if you're open to it, and I know not every employer is, but if you're open to it, we'd love for you to sign on the letter that Chris and Marianne have put together, opposing HB 3265. Diana just put it in the chat. The time sensitivity on this is very high. I think we pretty much have to have you do it today because we want to get that letter up to the House committee in time for its hearing tomorrow. And then you can learn a whole lot more at our webpage, which is listed here. If you don't want to, you can cut and paste the URL in, or if you just go to nationalalliancehealth.org, you can kind of click through and you can easily get to 340B where we've got a lot more materials, background, et cetera, et cetera. And with that, I'm going to start trying to answer questions. And then I'll pause and see if people have anything more they want to add. But we have a question from Jeff who said, in your example about loss of rebates under 340B, is the acquisition cost of the drug the same between a 340B patient and a non-340B? For example, the cost of the drug itself. Just wondering if the rebate loss is offset at all by lower prices. Great question, Jeff. I think the answer is no, it's not offset because there's sort of the standard price at which the drug would have been sold. They get the discount, but because they don't sell any of that discount onto you, or excuse me, they don't pass any of that discount onto you, it all flows to the 340B covered entity. The PBM would buy the drug at basically the initial price, pre-discount. The PBM would be able to negotiate rebates below that, which would get it closer to the 340B discount, although never as high. And you would get that delta, whereas on the 340B side, you don't. So effectively, you're buying the drug at a sort of pre-rebated amount compared to what you would get under your PBM arrangement, where you're buying sort of list price minus rebates. And Jason Sorrells asked, what programs are currently available to self-funded employers and their members to help them take advantage of the possible huge savings through 340B? All right, so this is a fantastic question, Jason, and I will happily answer it, both sort of the honest answer and the well, I'll answer it in sort of the various ways. So there are organizations out there, sort of think of them as kind of TPAs that are trying to get employers to actually move their employee population into 340B and have the hospitals have a shared savings arrangement with the covered entity. Some of them are, there's a place called Rescription. There's another, I can't remember all the names. They promise significant savings compared to sort of a traditional PBM model. We do not encourage you to take advantage of those for a couple of reasons. One, the loophole that they are using is, I think, likely to get closed, which we'll talk about in a minute. Two, they are, I think, seeking to take advantage of a program that's already broken, and this would in some ways just break it even more. Three, I think there's some legal risk here for an employer that gets involved in these programs. And four, I'm not sure the savings are actually as big as they would claim, because they would be often basing their savings based on what would you be paying if you didn't have sort of rebates already through your PBM. So the way these programs work is they have, imagine them sort of sitting in the middle of that nest that we talked about between covered entity, contract pharmacy, employer. They'll have a contract with each one. And they'll say, all right, we're going to drive as many employed people or their families into your hospital as a 340B patient, meaning you'll then be able to take advantage of those savings. With the contract pharmacy, they say, we're going to make them fill the scripts through you. And then with the employer, they're going to say, and we will pass on some of the savings to the employer. But the way that they do that typically is they will basically create a patient connection between the covered entity and the hospital or the community health center, if they're using a community health center as their partner. Typically, that patient relationship is a telehealth visit, maybe a single telehealth visit between a nurse practitioner and the employee, because they have to somehow demonstrate that this patient is a patient of the covered entity. It might be a 15-minute sort of well check. The nurse practitioner doesn't even need to prescribe a drug. All you need to do is have some sort of interaction between somebody who works for the hospital and somebody who is employed by that employer, or is covered under that employer. You now have a patient relationship, and then everything sort of flows from there. What it means is you're losing all the rebates that we talked about, and in a lot of ways, you're becoming complicit in taking advantage of a program that was designed for safety net hospitals and community health centers to get low-income drugs at a cheaper price for low-income people. I'm not blaming employers for doing this. A number of them have done it. I think employers understandably are desperate to try to get lower price drugs. We're all getting really hammered by high and rising prices. I just think if employers go that direction, they're taking on a risk, and I think are ultimately kind of getting involved in a program that is already being badly misused and sort of misusing it themselves. So that is sort of the way in which an employer could conceivably say, I'm going to get access to 340B and take advantage of it on my own. I will say there have been legislation out there to say that employers shouldn't even be able to consider 340B discounts in their reimbursement arrangements. I think if you had a direct contract with the hospital that you knew was a 340B hospital, to actually have bona fide, not just a one-off nurse practitioner call, but like a bona fide patient relationship. I'm sending all of my cancer patients to you because we think you're a center of excellence. Then I think knowing that they're a 340B covered entity saying, hey, you're making a lot of money on this. We want some of that. I think that's totally reasonable because it's a real, actual patient of that covered entity, not just sort of a made up fake patient for the purposes of trying to grab some of this money. So my answer. An anonymous attendee asked, what are your thoughts on Mark Cuban's Cost Plus Drugs company? He's been pretty vocal about targeting similar issues and wanted to reform healthcare industry. Great question. I will say in general, I'm a fan. I think we're all about disruption. The current model and the sort of the dominance of the big three PBMs is hugely problematic. And I like what Mark Cuban is trying to do. In fact, we are very pleased that we are going to actually have Mark Cuban, thanks to Marianne and her team. Mark Cuban is going to be a opening keynote at our summer leadership conferences, which are going to be taking place in Irving in June. So if you want to hear directly from Mark about what he's doing and how we think it kind of well aligns with what the National Alliance and our coalitions are trying to do to disrupt the prescription drug marketplace, I would strongly encourage you to come join us. I believe he's speaking on June 10th, but it's all available on our website. Mark Cohn asks, isn't it likely that given the current administration's trend toward securing open free markets to increase competition and drive down prices, that the 340B program will go away, allowing everybody to compete on an even playing field? Good question. I think the use of open free markets is an interesting one, just because I think that maybe applies domestically. When we look internationally, I'm not sure they're interested in open free markets, but that's a side item. I do think this administration is likely to be sympathetic to the arguments that we're making. I don't know that, well, first of all, the administration can't get rid of 340B as it stands, right? It is built into federal law. So it would require an act of Congress to fundamentally reform the law. I do think the administration could direct HRSA to crack down on a lot of things. And that I think would be really positive. And we are engaging with the administration to sort of make this case. So I think we are in a good spot for trying to get real 340B reform for the first time in a long time. I will also say we've been trying to do this with both Democratic and Republican administrations for years. We got nowhere with the first Trump administration. We got nowhere with the Bush administration. We got nowhere with the Obama and Biden administration. So I don't want to be overly optimistic, but I do think this administration in general is going to be more sympathetic to the concerns that we've raised. I think that's all the questions that have come up so far. I wanted to pause and see if Marianne or Chris would like to raise anything that I talked about or ask any more questions. And then obviously people can feel free to ask more in the Q&A.
Well, this has been just an outstanding program, Sean. Thank you so much for sharing the information. And I really like the idea. You gave a couple of really interesting examples. One of them, in answer to one of the questions, was on that perhaps employers could contract directly with the hospital, DSH hospital, or a hospital that has 340B contracts, and they're part of the shared savings. There are a lot of employers who are trying to do special contracts with hospital groups or certain selected places to have cancer treatment and so on. And I know that that's something that we probably could encourage some employers to do, to set up your own deal and get a piece of that. I mean, the drugs the hospitals are buying for 340B are pennies compared to what the prices are that they're charging employers and their employees. So why not get in on the game like that? What do you think, Chris?
It's easy to take the moral high ground. The program was intended to serve the underserved, and I get it. That we're a country of loopholes, and maybe this is one of those things. You do the right thing. And I think one right thing might be signing on to this letter. I'm going to ask Diana to pull up the letter. You provided the link. I just want folks to see that for a moment. And then if you can do that and then scroll down, essentially what this does is we're opposing the hospital assertion that any contract pharmacy be used, that there can be no guardrails, and so put your contract pharmacy in River Oaks, in Houston, and highfalutin areas elsewhere. And again, employers are the ones who are paying the price for this. But as Sean mentioned, you're seeing a decrease in the actual use in contract pharmacies where they're most needed. So this is the letter, and if you just scroll down to the bottom there, it's pretty easy. I did this. Scroll down to where you actually saw it. You just provide a couple things there, and it's said and done, and you sign on to it. And essentially, we're opposing the legislation that's out there, House Bill 3265, which says you cannot require us to provide any claim or utilization data to show that this is actually going to the right people. You cannot ask us that. It also says we can put a contract pharmacy anywhere we want, and you can't deny selling that at that particular contract. I mean, those are the two big things that this bill is doing. And what we're saying is, hey, hold your horses and let's at least look into this a little bit more before we put into etched in stone forever they may be, the practice that has been bastardized by this approach. So again, employers in the group. I also represent another organization called Texas Employers for Affordable Health Care. And I raise that because I can promise you that at the state legislature, the hospitals around the state and other providers utilizing this, they're united in their message. They may compete a little bit. They are united. Employers, for the most part, are absent. So the message to legislators is employers think this is fine. Obviously, they don't mind. But they do pay attention to your voice. And so, again, there's a short timeline. But it makes a difference if you ask or make your voice be known. So I just wanted to raise that for a moment.
I just want to add very quickly to supplement what Chris said. So the legislation does two things. One says you can have as many contract pharmacies as you want in high income areas to price gouge employers. But two, the other one is a really good point. Is we still don't know. Most employers cannot know to what extent their hospitals, or excuse me, their covered lives are being filled through 340B. There are efforts by drug makers to require basically a disclosure or the ability to sort of see a claims modifier to say this is under 340B, which we would then be able to get access to. So we as employers would start having a better idea of like what percentage of my patients are going to 340B hospitals? How much am I actually losing? The estimates that I provided in terms of loss rebates are based on average across Texas, but certainly for some employers, it's going to be more, some less, depending on where your patients are. They don't want that, right? So the hospitals are basically saying, we want this program to grow without any limitation, and we want to have no transparency. And they're trying to put that into Texas law to say they can't even be transparent for us to have a better idea of what's happening in the program.
Yeah.
And I would add that a lot of employers in our coalition and employers across the state of Texas, number one, probably don't know much about the 340B program, that we're happy to bring it to and call it to their attention. The legislative session is short, looking ahead at this year's, but more importantly, the value of this particular discussion today and what you've shared with us, Sean, is to just be aware of what is happening in this highly expensive program for employers that have their employees going to these hospitals that are charging those exorbitant prices that they paid so little on of the pharmacy drugs that are being used. We just need to know more about this. We need to be educated on this, and we have to make the employer's voice known. So one of the values of participating in a webinar like this is that employers from across the state can join in or learn in a complimentary webinar like this and find out about some egregious problems that are going on across the state by the healthcare system, and employers have got to stand up and speak for the advantages of their own companies and their employees' healthcare as well. And the cost is becoming unaffordable for so many companies and so many employees. So this is our interest as a business coalition. We love to support the Texas legislature on issues that are important to employers, and national legislature that's important to employers across the country. And my point is to continue to tune in to Houston Business Group on Health, Dallas-Fort Worth Business Group on Health, Texas Business Group on Health, which covers the coalitions across the state, the three main ones, Texas, Houston, Dallas-Fort Worth, and San Antonio. And let us help you learn more about the issues that will help you make healthcare affordable for your employees. So with that, I think we're in one last minute. Any last comment other than my great thank you to you, Sean, for doing this for us?
My pleasure. Truly, you guys have been are terrific. I hope all of the attendees know that you've got two of the best employer coalitions in the country working for you. And we've got a question from Daniel Reed. Is there a chance the slides will be shared? I think I know the answer to that, but this is Marianne and Chris's webinar. So will the slides be shared with the attendees?
Great.
Excellent.
So thank you all for participating today. Chris, thank you for co-hosting this with us. We're just absolutely so grateful to National Alliance. Thank you for sharing Sean with us for today's webinar. Some really important stuff.
Thank you, folks. Bye, everybody. Have a good rest of your day.
Have a good rest of the day.
Bye now.